Hey everyone, welcome back to The Explainer. For all you certified coders, auditors, billers, and CDI specialists out there, you already know that mastering E&M coding is just, well, it's absolutely crucial. Today is actually a huge milestone for us. We are hitting part 13 of our 15-part training series. We're diving into a prolonged services masterclass. We're going to zero in on CPT add-on code 99417, its Medicare twin CMS G2212, and those notoriously tricky extended time thresholds that govern them. So let's just jump right in. All right, here's a quick look at our roadmap for today. We're going to define prolonged services, hit the fundamental rules for 99417, compare the CPT and CMS time thresholds, run through a really practical step-by-step math drill, and then wrap up with some compliance pitfalls you definitely want to avoid.
Okay, starting right at the top with Section 1, Prolonged Services Defined. Before we even think about touching the math, we really need a rock-solid foundation on what these codes actually mean.
So what's really interesting about 99417 is how explicitly restricted it is. It's an add-on code meant to capture extended time spent on patient care, but, and this is a big but, it only kicks in when you go beyond the highest level primary E&M service time. So, practically speaking, we're strictly talking about office or outpatient settings here, and you have to have already maxed out your primary codes. Think 99205 for new patients or 99215 for established ones. Basically, you can look at this code as a specialized accounting mechanism. It captures that extra, grueling provider time that would honestly just go completely uncompensated otherwise.
Moving right along to Section 2, Fundamental Rules for 99417. Let's layer on the strict prerequisites for actually billing this thing.
Now, you can't just slap a 99417 onto any claim because the visit felt a little long, right? There are some pretty rigid compliance rules. First off, it has to be billed on the exact same date of encounter as the primary service. Because it's an add-on code, it's always billed in addition to that maxed-out primary E&M. Third, and auditors love looking for this, it can only be reported by physicians or QHPs for time they personally performed. Then there's the 15-minute rule. You use this code for each full 15 minutes of prolonged time. But honestly, the absolute biggest prerequisite, the one that trips people up all the time, your primary service level must have been selected using total time, not medical decision-making. If you leveled the base visit using MDM, prolonged time codes are just completely off the table. Period. Don't even try.
All right, Section 3, CPT versus CMS time thresholds. We're getting into the payer nuances now, which is exactly where coders face the most confusion and, frankly, the highest risk of failed audits.
This brilliantly illustrates the glaring discrepancy between CPT rules and Medicare rules. Let's take an established patient first. Your base code is 99215, which has a time threshold of 40 minutes. Under standard AMA CPT rules, your first unit of prolonged time kicks in the second you complete a full 15 minutes over that base. So 40 plus 15 is 55 minutes. Boom, you hit 55, you bill 99417. But you know Medicare loves to make things interesting. CMS, using HCPCS code G2212, does not agree with this math. They require you to go a full 29 minutes past the base maximum before that first prolonged unit legally kicks in. So for that exact same established patient, Medicare won't let you bill prolonged services until you hit 69 minutes. And you'll see that same painful gap for new patients too. Base code 99205 is 60 minutes. CPT says add 15, so you bill at 75. CMS says add 29, so you can't bill until 89 minutes. This right here, this is the literal difference between a clean claim and a nasty denial, so definitely keep this logic front and center.
Okay, Section 4, Step-by-Step Math Drill. It's time to put on our auditor's lens and actually test these thresholds in the real world.
So imagine a claim crosses your desk. The provider documents exactly 71 minutes of total time spent with an established patient. And they've already indicated they want the primary service coded as a 99215 based on that time. Let's break down exactly how you need to correctly score this without triggering any alarms. Here's the exact calculation pathway. Step 1, isolate your base time. We know 99215 covers the first 40 minutes of the encounter. Step 2, find your remaining time. We just subtract the 40-minute base from our 71-minute total, and that leaves us with 31 minutes of prolonged time. Step 3, we divide that into 15-minute blocks. Well, 31 minutes neatly contains exactly 2 full 15-minute blocks, which is 30 minutes, leaving just one single unbilled minute left over. So Step 4 gives us our final, perfectly compliant code string. 99215 for the primary visit, plus 99417 times 2 units. By working through it step by step like this, you're maximizing legitimate reimbursement for the provider while making absolutely sure the math is audit-proof.
That brings us to Section 5, Pitfalls and Key Takeaways. We've got the math down, but let's review the compliance traps that will immediately trigger an auditor's red flag.
I really want to draw your attention to this direct rule right out of the guidelines. Do not use 99417 for any unit of time less than 15 minutes. I know it sounds super simple, but you'd be surprised how often it's violated. Listen, if you have 14 minutes of leftover prolonged time after your primary code, that time is entirely unbillable. You literally cannot claim it. Rounding up is a massive compliance violation. You have to hit that full 15 minutes to trigger the unit, or you are just handing the payer a super easy reason for a clawback.
Building on that, the documentation itself has to be flawless. Exact time absolutely must be documented. The provider has to state something like spent 20 minutes. If they write a range, like spent 15 to 30 minutes, you can go ahead and throw time-based coding right out the window. Now, start and stop times aren't strictly required by CPT, but a single specific total time is 100% mandatory. If the exact time is undocumented, or if it falls below the minimums, you have to revert to leveling the visit using medical decision-making. And here is why this matters so much to your facility's bottom line. Sometimes a patient's MDM might only support a level 4 code, like a 99214. But if the provider spent a massive amount of time counseling that patient, valid time-based coding can legitimately boost you up to that 99215 level plus your prolonged codes. But exact time is the absolute bedrock of that billing. Without it, you really have nothing.
Well, that brings us to the end of our deep dive into the numbers and thresholds of prolonged services. But before we go, I want you to ask yourself, how much legitimate reimbursement is your practice bleeding right now simply because providers are writing ranges instead of exact minutes? Definitely something to think about. Next time, in part 14 of our series, we're flipping the script from time back to MDM with a deep dive practical case study. We'll be walking through step-by-step MDM scoring for an established patient, so make sure you review those MDM tables before we jump in. Until then, decode healthcare with Harshal.